There we go. Okay, I've got some questions. And I'd like to just start with the why the procedure is called Flourish.
I think that's a great question. I'm not the one who named it. It was named by Dr. Zeritzky, the inventor, who's an Argentinian radiologist now working in University of Chicago. And I perhaps because when babies are able to feed, they will flourish. So, but that's a great question. I don't know. I don't know exactly how they came to that name.
It's quite poetic, really, isn't it?
Yes, and I think it definitely is a nicer term than if they had, the medical word for it is now, it's not a word in the dictionary, but the accepted medical term is magnemosis, which is magnetic anastomosis. So it's a combination of the two. I don't think that would have come across as a very, interesting description. So flourish, I guess, is much more, it's also, I think it's a much more inviting term.
It is. It's kind of magnemosis is sort of switch off time, really. I suspect for if you know nothing about it. That's great.
And even the word anastomosis is difficult for many people to pronounce. So
it is, but it's one of those words that once your child has been born with this condition, it's part of your vocabulary.
Absolutely, that's right, and that's really interesting what you're saying, because parents definitely acquire a new vocabulary as soon as there's a new condition that they may not have been aware of before.
Well, so the name of the doctor surgeon you mentioned, I'm afraid I missed. But so when and where was the procedure first trialed?
Yeah, so it's Dr. Zeritzky, Zeritzky. I'm happy to send you his contacts. He's very approachable, very happy to talk about it. The timing, I think it's great. I have to say I'm not, again, completely clear on whether he actually developed this in Argentina and then brought it to the US. I know that Cook has been looking at a device like that for well over a decade, if not longer. But I can't say that I know the details of how the product was developed. I mean, I know that there have been some experiments in animal models looking at these types of anastomosis, but the history of how this came about, I'm afraid I'm not totally familiar with.
No, that's fine. When did you first perform it? How long have you been working on this?
Yeah, so I wrote a chapter on esophageal atresia from the book that I authored. This was published in September 2019, it's 2 years old. And so I wrote that chapter. That was actually the very last chapter I wrote for the book. So it was written in December 2018. And when I wrote that chapter in December 2018, I tried to present the most up-to-date options available for patients with esophageal atresia. And I came upon this option of the Flourish device, magnetic anastomosis. It's interesting because I have a very short paragraph on it at the time, had not been used in Canada much, and in the US it was still available on a compassionate use basis through an FDA approval. And then, time went by, and in, let's see, June of 2019 is when my patient was born, who sort of made it to the news and so on. And he really had the most severe form of pure atresia or type A atresia, meaning that not only was there a long gap, there was no distal esophagus. So the only distal esophagus was a small, 1 centimeter below the diaphragm. And that's what got me thinking that we now have to look at options outside the box. So that late summer, so he was born in June, late summer, there was a big surgical conference here in Montreal, and Cook was there as one of the companies, presenting their products. And I went and met with them and explained to them about the issues with my patient. And I really that's the point where I started learning a whole lot more about it. So at that point, I read everything that has been written on it. And there had been not a lot of literature, but there'd been 3 or 4 papers, mostly case reports. There was a couple of small case series. I also had to start looking into what would be needed for a Health Canada approval and so on. So it really became, I spent about, I would say, 6 weeks in a pretty intensive self-education process to understand exactly what the criteria were, how the options would be. And even when we operated on the child on October 10th. And even when we operated on the baby, it was still an option. We had the device, but we were still hoping to be able to do a primary anastomosis. And only when we could not, then we decided to do that, because there was just, we confirmed that there was no distal esophagus. So even with mobilizing that tiny small esophagus into the chest, there was still a very large gap. And so that was the process of how I came upon it and learned more about it.
How did you feel when you started off doing that operation on that little boy? Were you very nervous? Was it, I mean, I guess you work with tiny infants all the time, but this was something so new.
Yeah, it's I don't use that word lightly, but it's a terrifying experience. It really is. I mean, the one thing that sees us through it is that it truly is a shared decision-making approach with the parents. So you don't feel like you're just doing something sort of crazy or outside the box on your own. The parents were very, very involved. They knew what the options are. They were very updated. In fact, they met with the representatives from the company before, and really we went through a significant education process for all of us, and that team included the parents. But it was the first time to be done really in the world, not, I wouldn't say in the hospital or in Canada, because we had never done a hybrid procedure, meaning, mobilize the esophagus and then apply the magnets. And we prepared very well. We made sure that Dr. Zeritzky was with us. So he actually came from Chicago, and he was with us during the procedure, and several of the company reps. I mean, of course, we had to get Health Canada approval. And so we really went through a significant process of dotting the I's, crossing all the T's, and going through simulations of how it would actually happen. And so that is a source of comfort. But finally, I just felt like there wasn't really a lot of options at the end. And it was either we say, okay, this esophagus is just not there, we cannot use it, and we have to do some type of transposition, in which in our practice, we really, there's different philosophies of how to take care of esophageal atresia patients in parts of the world. And in some surgical centers in the world, interpositions are done relatively soon. In our philosophy, and it's, I would say, in much of North America, I don't think there are many people who disagree about this in most US and Canadian centers, is that we really still try to preserve the native esophagus, if it at all can be preserved. And so really, in order to do that, there wasn't really much options, because this esophagus, even after we mobilized everything, would not come together. And then we had to employ this. So you do something like that, you have no idea how tomorrow would look like, or is there going to be success or failure? And of course, if there's failure, then you've just lost whatever esophagus you had. So the risks are very, very high. It's the same with any of these procedures. I've been involved in so many, of these newer procedures, and we go through the same process. It's about preparation, weighing the risks and benefits, shared decision-making with the parents and the family, and then really still having a rational approach, so that you're not in an adventure. You have a good rationale for why you're doing what you're doing. And thankfully, most of the time, if you do all that homework, things do go well, but sometimes they don't. And, that's part of the risk we share with patients. And I do a lot of praying. That's the other thing that really sees me through.
Can you, if I were a new parent, new baby, and you thought you might have good success using this procedure, could you describe to me, as a new parent, a layman, how the procedure works?
Right. So the idea is actually an idea that's not new. And that is that all human tissues are amenable to stretch. So we know that from many different examples of things we do. For example, I do a lot of surgeries to repair chest wall anomalies. And it used to be, you have to remove cartilages and break the sternum and correct it and so on. And now we know that we can actually stretch the chest wall by just putting a metal bar to expand the chest wall and leave it expanded for some time. And the orthodontists use this in, changing the jaw bones and changing their position. The orthopedic surgeons have used something called an Ilyasarov apparatus to lengthen the bone. So all human tissues are amenable to lengthening, and that includes the esophagus. And of course, for a couple of decades now, there has been the Fokker procedure, which it's a way to stretch the esophagus and slowly bring the two ends together, literally through pulling on the ends. So we know that that works. The problem is that most of the procedures that have done this to the esophagus, most of the stretching procedures are also very traumatic because you're literally pulling hard on the tissues. And certainly with procedures like the Fokker technique, which many parents of children with long gap atresia have heard of, there's been, people publish their successes, but don't often publish their failures. And that's really kind of a sad commentary about our field. And I'll address that again in a minute, because it has a lot to do with this particular magnet procedure. But the problem is that most of us have seen sutures tear and leaks from the esophagus and damage to the esophagus with this technique. So the idea of the magnets is not different from the Fokker that parents are very aware of, but it's gentle because you're not doing any severe traction. You're not pulling on the tissues. There's no sutures in the tissues. So the idea is to put the magnets and really allow gradual approximation by stretching of the esophagus. And that was what was very appealing to me. Now, having said that, we've had pretty good results, and it's not something that we do every day. We've had 2 patients. One patient is patient, Henrik, who was written about quite a bit, who did very well. The other patient were able to get an anastomosis, but had other issues also. So we had to deal with other sets of complications. But in both patients, we were able to get an anastomosis. But there have been now, just through speaking at our meetings, we just completed the Canadian Association of Pediatric Surgery meeting. It ended on Saturday. And, we share experiences, and there are reports of people using this device and not having good outcomes. So we are actually in the process of putting a national Canadian study together of the magnetic anastomosis, because all the series that have been published are about success. But we now want to publish and show how many succeeded and how many failed, and what were the criteria or determinants of who succeeded and who failed, because we believe that this is really what is needed to be honestly shared, both in our community of pediatric surgeons, but also with parents who are now, as your organization does, doing a lot of research through support organizations and online. I get calls now at least once a month from around the world, Singapore, Vancouver, places in the US, India, everywhere. People are struggling with the same thing. How do we do this, and can we use the magnets? And I just got a call today from a surgeon in Calgary who wants to have a meeting to figure this out. So we need to share this honestly and really see, okay, this is something innovative, it's something new, but who is the best candidate for it? And we don't have that answer yet, unfortunately.
Okay. And so technically, in layman's terms, what do you do with those magnets? I'm a new parent. I would like you to explain to me what is going to happen to my child tomorrow.
Yeah, I actually, unfortunately, I left my hard drive at home today, but I would have been able to show you a PowerPoint, but I can describe it pretty simply. Yeah. So
I have actually looked at the Cook's video diagram.
Okay.
So I have an idea, but I would like to be able to explain that to our readers.
Right. So, as most parents know, when we have a long gap atresia, there's an upper pouch and a lower pouch. And those pouches usually are no longer connected to the trachea, because most pure atresias do not have a connection to the trachea. And those that do typically had that connection divided by a surgeon before the surgeon is able to put the ends together. So the idea is to introduce one through the mouth, a magnet through the mouth, and it's on a long catheter that also acts as a drainage tube, so that the same catheter that has the magnet at the end is like a nasoesophageal tube that drains the secretions. And parents are aware, of course, babies with this often have to have their secretions suctioned. And so one of the magnet is 8 millimeters. It's a kind of it looks like a small button, if you will, and it goes in the upper pouch through the mouth. And then the child has to have a gastrostomy. It's not possible to introduce it without a gastrostomy. Almost every patient in that situation already has a gastrostomy. So once again, the device that has the magnet also acts as a gastrostomy. So there's a feeding port. So that is introduced into the lower pouch, and that is done under fluoroscopy. So if a patient, for example, has a long gap atresia and has never had surgery, and their gapogram, the study we do in radiology to show how long the distance is, shows that they're within 3 centimeters, then the magnets can be introduced without any surgical procedures, just done in the fluoroscopy suite. But if a child, and this is what we have been, kind of teaching people about, is that it's not an all or none, because people have felt either you do surgery or you use the magnets. And our experience, of course, it's an experience of 2, but it's an experience that we are hoping to publish, and we like to be responsible about our publication. So the child we operate on will be about 2 years out of surgery soon. So then we will have a really good true outcome on what we have, because it's easier to publish early outcomes, but they may not be necessarily the long-term outcomes. But that's what we're trying to share now with a lot of surgeons, is that it's not binary. It's not magnets or surgery. You can actually have hybrid procedures, meaning mobilize the ends of the esophagus, but don't traumatize them by trying to do a very tight anastomosis, which is amenable to leak and severe stenosis and damage, etc. You can mobilize by one of many techniques. In our case, we had to divide the stomach and bring part of the stomach and esophagus up, because there was no lower esophagus at all. And then you can apply the magnet. So ours was the first hybrid procedure to ever be done. And that's why, Dr. Zeritzky himself was here, was very interested. He refers a lot of surgeons to us now. And that's really what we're trying to explore now as a new option. And if the magnets do not work, then you always have you haven't really burnt any bridges. But this is what we're exploring. Have the magnets caused damage to the esophagus? Have they caused leaks? And that's really what we want to do through this Canadian national study. We have about 5 or 6 centers in Canada who've used them. We want to put all our experience together.
Okay. Has I suppose at this early stage, it's impossible to know whether anyone's experienced an intolerance to the metal that's used in the magnets.
Metal allergy is very, very, very rare. And usually it develops later in life. So for example, I mentioned the PEC test repairs. We do test patients for metal allergy because we're putting a stainless steel bar in these patients. And if a patient ever had an allergy to a watch or a chain or something like that, we always test them. And then we use other metallic components that are not stainless steel, because they're usually allergic to the molybdenum in the stainless steel. But an early allergy in a baby to a metallic stuff would be really, really, really rare, super rare. So I don't think that has ever been reported as a problem.
How long does it generally take for the 2 ends to fuse together?
Yeah, if it's going to work, it should happen within 10 days.
Oh, yeah. Wow.
Yeah. And in our case, around, I believe, day 9 or 10, we had it. But it's also may need, so you can't just put the magnets and just wait, because what happens is these magnets, they're not sutured inside the esophagus. They're just sitting freely inside. So even though we keep babies sedated so they don't pull on things and so on, they can move. So it's important to follow. And if they look like they're kind of moving away from each other, we have to go back to X-ray and approximate them again. So in our patient, we had to do 2-3 trips to the fluoroscopy suite for X-rays to make sure that the magnets are staying approximated and not moving back. And then I think it was around day 9 that we actually found them finally to have met each other. When the magnets are kissing, the anastomosis is there. And very predictably, what happens is the tissue of the esophagus will necrose and essentially melt away. And that creates a fever in the child. It's a benign fever. It's not because of an infection. Any tissue that dies will cause a fever. So when we have that fever, we know that the tissue is dying, which tells us that the wall of both ends is now melting away. And then 3-4 days later, we take the child to the fluoroscopy suite, pull the magnets out, and do our first study. Now, it's very important to understand, by definition, every child who gets a magnetic anastomosis will have a stricture, because it's only 8 millimeters. So by definition, they will have a stricture. So we know ahead of time that anastomosis will have to be dilated or addressed. But in most of these patients who have very long gap atresia, really, no matter what you do, you often will end up with a stricture anyway. So it's not an unusual scenario.
They're tiny, these magnets, presumably, absolutely tiny.
8 millimeters. Yeah.
Okay. Do you think it hurts having magnets inside you?
Unfortunately, we'll never be able to ask the babies, but I don't believe so. I mean, we put metallic components in older patients all the time, for fractures. I mean, they're very common to put metallic components in patients that are left for a long time, and we don't see chronic or acute pain syndromes from that. So I would probably assume not.
Would you contemplate doing this procedure on a newborn that's just immediately been diagnosed with OA or EA, what do you call it?
Yeah, so I think that's a fantastic question, because I think there's dogmas and there is sort of innovation, and the two are often trying to find the middle ground. So the dogma in pediatric surgery has been, when there's a long gap atresia, you leave the baby for 3-4 months. Yeah. And in our Western countries where we have resources, they often stay in the hospital. Sometimes parents arrange for suction at home and so on. But I would say for the most part, these babies are in the hospital for the first few months. Very interesting, because I do a lot of global surgery work, and I travel around Africa and so on. And in places, for example, in North Africa and Egypt, surgeons are very skilled at doing interposition. So they don't have the resources. There's no way that a patient, the hospital or a family will afford to have a patient in the hospital for 3 months. So there, the approach is dramatically different. The baby with long gap atresia gets an esophagostomy so they can drain their saliva, and the gastrostomy, and they go home. And then they come at a year of age and get a colon interposition. Very different outlook. But the idea is, okay, do we really have to wait the 3-4 months? Because that's the dogma. That's what we want. And why do we do? Because we believe that those ends will approximate with time. And there's a lot of evidence that happens. But with these newer techniques, where we may not need to wait until the two ends are that close together, yes, I think the question is, yes, it may be amenable to an intervention, not on the first day of life, because you still have to know how long of a gap you have and so on. But certainly if you get a baby with a pure atresia now, you will do a gastrostomy and you will do your first gapogram to find out the distance between the two early at 2 weeks. And if it really is already within, 2, 3, 4 centimeters, you really should start thinking, should I be waiting another 3 months? Or should we go ahead sooner with something like possibly the magnetic anastomosis and try to get an anastomosis much earlier? Because what keeps these patients in the hospital is that they're not unable to swallow.
Is it possible to do the procedure on a baby that has esophageal atresia and tracheoesophageal fistula, or does the TOFS have to be dealt with first of all? Or
that has to be dealt with. No, you cannot have any connection between the two. So if it's a type C atresia, where it's the most common type, where the distal esophagus is connected to a trachea, that has to be divided first. And most of these cases, of course, we can put the esophagus together. But if you do happen to have a very long gap, then you can divide the trachea and put the magnets. Or if you have an upper fistula, and that has been actually one of the Achilles heels of this procedure, because you cannot have a fistula. The fistula tethers the esophagus, does not allow it to lengthen. So lower fistulas are very easy to diagnose. Upper fistulas can be very difficult to diagnose, even with endoscopy and all that. So if you put the magnets and there's an upper fistula, you may still be able to get anastomosis, but that's when you can get leaks and other complications. And our second patient that I mentioned had that. So we were not able to confirm an upper fistula, and we were able to get anastomosis with the magnets, but we still had to go back and operate to divide the fistula and reattach the esophagus.
In your experience, does long gap atresia occur more frequently if it's a patient that doesn't have the fistula?
Yes. Exactly. So long gap atresia, so about 8 to 10% of all atresias are atresias without a distal fistula. And of those, a very small number will have an upper pouch fistulas. So those are the great majority of ones that people struggle with. Every now and then you could have the common, what we call the type C, where there is a fistula, but if the fistula is very low to where the trachea bifurcates at what we call the carina, where the trachea splits into two, then the gap between the two ends can still be very long. And that's, again, a surgical decision. Does the surgeon just close the ends, come back later to try to do something to bring them together, or you still try to put them together under tension? And unfortunately, there is no real science behind this. It's a surgical decision made on the spot. And it really has to do with the experience I've had as a surgeon. And you know, it's not just about the number of years you've been doing it, but also who is in your group. Because, you know, we often treat these patients as a group of surgeons, and of course, as a team of physicians in a multidisciplinary way. So it's very common, if we have a very difficult scenario like that, for us to have essentially a conference. I mean, we have 7 surgeons in our group, and we really often bring it back to the group and get everybody's input. What is the best way to proceed with this? We have a group discussion of the pros and cons. You know, the motto we have is, if you see one of us, you see all of us. So it's often not just the surgeon, and I think this is really one of the silver linings of the horrible pandemic, is that we've come together a whole lot more as a community around the world. Like I said, we meet with surgeons from Singapore and all kinds of places lately in these Zoom meetings, and they can show us the studies. And often the last meeting we had with surgeons in Singapore, the parents were also there, you know, and it was wonderful to have the surgeons and just be very transparent about the struggles, and the parents to be hearing the discussion. You know, it really, I think, gives the parents a tremendous sense of peace to know that they see what all the discussions are. They're part of the decision making, and see that their surgeon is seeking help. I don't think it diminishes any surgeon to seek help. I think that help builds confidence and trust.
Yes, and I mean, just the very fact of how 30, 40, 50 years ago, whatever the doctor said was kind of sacrosanct, and you don't need to know about that. And now, fortunately, we do need to know, we want to know. And so in that sense, those Zoom meetings are terrific.
Yeah,
so
it's really interesting that you say that, because during this CAPS meeting on the weekend, we had several papers on communication with parents, shared decision making, and I tweeted, I don't know if you're on Twitter, but I tweeted a very simple thing. I said, shared decision making and patient reported outcomes is the future of pediatric surgery. And I really believe that.
That's great. And internationally, as you say, yes, across the world, now we can do that. So
absolutely.
Yeah. It's thinking along those lines. Do you have an idea of how many OA patients have been treated in this way worldwide?
I wouldn't be surprised if it's well over 100 now. The last paper that came out was a case series from multiple institutions, and if I'm not mistaken, it was published only about a year or two ago, not so long ago, quite recently, and it had 17 patients from different places. But just anecdotally, because of, again, our community is reasonably small, you know, pediatric surgery community is small, so we get a lot of kind of anecdotal feedback. And the company would probably know, because they have a database of all patients who've been treated anywhere in the world. And there's actually a United States study going on, a prospective study, where every patient is enrolled prospectively to gather their outcomes, which is also going to be very good, but it probably won't be published for some time. But I would gather at least 100 patients. I think I would be surprised if it's less than that. Do
you think this is the way forward for dealing with long gap esophageal atresia, this particular procedure?
No, I think it will be yet another option. You know, we have this dictum in surgery that when an operation has so many options, the reason they're there is because there's no option that works well for everybody. You know, and you still have to look. So I think it's yet another option. It's yet another weapon in an armamentarium of things we can use to tackle this difficult problem. But I don't believe it will become the solution for everyone, because many patients with long gap atresia can still be approximated. It can still get a safe primary anastomosis. So you know, like everything that happens, it's always a pendulum. You know, when a new innovative solution comes out, everybody's kind of, the pendulum swings to it. It's okay, this is going to do it. And then as you build the data, you build the experience, you find that there's successes and there are failures. the pendulum swings again. It's okay. Not everybody's going to benefit from this,
Yeah.
and this is
Not
what's
everybody.
happening as we speak with
Yeah.
the magnetic anastomosis. You know, as more data comes out, the successes are there, the failures are there, but
Yes.
we're starting to realize it's not going to be for everybody.
Yeah. Do you know if patients who've been treated with Flourish are as prone to strictures as, you know, any other kind of treatment they've had?
Yeah,
And
so
reflux?
they will all get a stricture. So that's the thing, is like we expect them to get a stricture because anastomosis is very small caliber, you know, 8 millimeters. So
And,
they will.
and that
They
will
will.
continue in the same way as
No, so right. So no, so I think it's no different than dealing with a difficult stricture in any patient. And there are patients who have very difficult strictures from surgery. And it's really no different from that. Our patient had to be dilated a few times, and then we put a special made called an Italian stent. That's a very gentle stent to keep the anastomosis open. And it's been a year now.
Okay.
And the child is doing marvelous. In fact, I'll be closing his gastrostomy very, very soon, eating everything by mouth, doing fantastic.
And are the patients still prone to reflux, as so many other, you know, children born with this condition are?
Yes, they will have. I would expect most of them to have significant reflux and have to be on reflux treatment for a very long time, and they need to be monitored. Most patients with EA now treated in multidisciplinary centers in the West have regular monitoring. And for example, we always do an endoscopy at 3 to 4 years to look at how the esophagus looks like. We do that routinely on all patients, every single patient with esophageal atresia, because there's a lot of silent reflux that causes esophageal damage. So, and each multidisciplinary group has its own protocol. But yes, they will have reflux, and it does have to be treated quite aggressively.
And esophageal dysmotility as well.
Yes, but you know, the esophagus, by definition, esophageal atresia is a tube. It's not a structure that peristalsis, or, I mean, it is never a normal esophagus. And the reason patients do well with that is that if you've had an esophagus that is peristalsing and, you know, has waves that propel the food down, and then it stops, you're very symptomatic, because, you know, that's what achalasia is. Achalasia is a disease where your esophagus was working fine for decades, and then suddenly it stops contracting and you're blocked. But in children with esophageal atresia, they've never known what a normal esophagus is. They learn to swallow in ways that work for them. And that's why they do well, because they never use their esophagus as a peristaltic tube. They use it as a gravity tube. Yeah. And, you know, every now and then there will be obstructions, and I'm sure you're familiar with all of that and food getting blocked. Yeah. But really, the majority of them do super, super well because they've adapted to their esophagus from very early on. That's the beauty of childhood, is that, you know, their ability to adapt is amazing.
Yeah. My own son, who was born with OA TOFS, is now 36 and a father himself, and has done very well. But I mean, there were many difficult years when he was very little. He had a long gap, but Mr. Kiley was able to join it. So yeah.
And you brought another excellent point, because I work a lot with families, and it's really being with families that's the most important, not even the surgical procedure. But I often tell them this, you know, children may stay at the hospital for very long and need multiple procedures. And my only advice is, you know, I know how discouraging it is when every time you cross a line, you feel like there's another line that just lit up in front of you. But you really, you have to do your best to look at the horizon as much as possible, because the horizon is usually quite bright for most of the patients. But when you look under your feet, it can be very, very difficult. And that's really always my advice, is to try to look at the horizon.
We have a very, very supportive Facebook group, as well as the almost 3,000 members of TOFS.
Yeah, that was the one that was born unable to swallow a group, right?
That's right, yes.
Yeah. I get a lot of messages from that group.
I'm sure. Well, we have about 110 or so members in Canada and North America, but worldwide we've got 2,800 members.
Wow.
And, you know, I was going to ask you, actually, if you were likely to be at the international conference in Cincinnati in October 2022.
Yes, so we actually held the very first meeting here in Montreal. I don't know if you know, because they were happening every 2 years. I don't know if they're still happening every 2 years or every year. So we hosted the first one here, October 2012, I believe. Anyway, but somebody from our group always goes. Yeah. And I you know, now we've been doing everything by Zoom, but I'm hoping that next year will really be the year we open up. Yeah, and I would very much look forward. So you usually have people from your group going
We
to those
do.
meetings?
We will have a presence there, yes. So
Excellent.
if there is somebody there from Montreal, then we'll be looking out for you and saying,
Yeah, absolutely. Absolutely.
Can I just finish off by asking you about how long did it take? How long was that operation, the one you did on Denik is his name? I'm not sure.
Yeah, Henrik Denin. Yeah,
Yeah.
it was almost 10 hours, and it's not because the magnets took 10 hours to put in, but because we still spent quite a bit of time. So the way it went is we went by thoracoscopy first into the chest, with a camera, to really confirm that there's no distal esophagus and to mobilize the upper esophagus. And that took several hours because we still were hoping to find something in the chest, but they really finally, after all the attempts, we found nothing. So that took a while. Of course, there's anesthesia time. And then in our case, we did a Charlie operation, which is that part of dividing the stomach, opening it like a book and bringing the top of the stomach up into the chest. So that took a few hours, and then applying the magnet. So the whole thing took about 10 hours. But if you were to just do a mobilization and placement of the magnets, I think it would be about a 3-hour operation or so.
Okay. So I'm just wondering how you prepare yourself for something like a 10-hour operation on a very new procedure, and how you get through it and how you feel at the end of it.
Yeah. At the end of it, you feel completely spent, like you just ran a marathon. So that's how it feels at the end. When you go through this experience, you don't think ahead, like, how am I going to be in a few hours? It's really like a moment at a time, and every moment has its own challenges. So you make sure the anesthesia goes safely. Then, you make sure that the part you're doing, for example, if you're mobilizing the esophagus, is that just what you're concentrating on? And you need to get that task done. And then you get that task done, you feel good, you've accomplished a task. You move to the next task, and so on. And that's really how you get through these very long, challenging procedures. Now, I have to say we're quite fortunate in pediatric surgery because, unlike many of our adult colleagues, we don't have that many of these very long procedures. Some of our adult colleagues have procedures like this, every week. And we don't. Most of our procedures, like if you repair, do a repair of a regular esophageal atresia, it's a 3-4 hour case, and that's considered long for us. So it's not, so, I think because of that, we're really able to anticipate that this is sort of like going in and knowing that you have to resect a very aggressive tumor, and that, sometimes we're there for 17, 18 hours and we take turns and so on. And it's just to get your mindset on that. One of the blessings of being in a long case in the operating room is that whatever else is going on in your life, whether it's in your personal life, your professional life, issues at work, people asking you to solve problems, whatever it might be, you can actually block everything else out for that period of time. You don't have to worry about a thing, and you're just focused on a single task. And if you think about how we conduct our lives, that's not so common. Usually we're trying to multitask all the time, every minute of the day. But it's a different mindset when you enter an operating room and you're doing a task like this. Everything else is now on hold, and it really doesn't matter what is happening outside the operating room. You're only focused on a single task.
And how do you feel at the end of it when the final stitches?
It feels exhilarating to be able to have accomplished. I mean, in Henrik's case, the fact that we actually accomplished what we set out to do was exhilarating. It is extremely exhausting. The mental exhaustion is intense. It's hard to carry on a conversation, for example, going home and talk to your wife and kids. It's really hard. It really is hard because they haven't been part of it, and they think, oh, you just came home, it's like another day. But it also is I don't want to be too kind of mushy about it, but it really does feel like a privilege. It really does to have had been able to be given the trust to perform something like that. It never I've been doing this for 20 years, and it never feels just like, oh, it's just another case, just another surgery. I mean, it has never felt like that. My partner, who we worked together on this case, he's been practicing for 35 years. And exact same thing for him. I mean, it never gets old. It's not routine. And we're really fortunate, I think, to be in a discipline where things just don't become normal. And I would say that that's true for pediatric surgeons probably around the world. I think the privilege of taking care of kids never is taken for granted.
Oh, that's brilliant. Thank you very much.
Yeah.